Today we have our clinic staff going to be doing some presentations for us on Good Drugs Gone Bad, the Suboxone program, and then also some testimonials from some individuals that are enrolled in that program. I think Dr. Gunter is our first presenter.
I don't know if you can see this or not, but it's kind of a lengthy definition of what addiction is according to this American Society of Addiction Medicine. Addiction is a primary chronic disease of the brain. Motivation, reward, memory related to the circuitry. Dysfunction of these circuits leads to characteristic biological, psychological, social, and spiritual manifestations reflected in individual pathologically pursuing reward and relief by substances or other behaviors. Addiction is characterized by inability to consistently abstain, impairment in behavior control, cravings, diminished recognition of significant problems of one's behavior and interpersonal relationships, dysfunctional emotional responses. And like a lot of other chronic diseases, addiction often involves cycles of relapse, remission without treatment, or engagement in recovery activities. Addiction is progressive, can lead to premature death and disability. It's kind of a lot to unpackage there, but it's a simpler version to think of it as it's a chronic, relapsing disease characterized by compulsive seeking of drugs and use despite the harmful consequences. Some people realize they have problems, some people say, I don't have a problem, they think everything's fine. But this, where it's different, drug dependence, we'll talk a little bit more of this later. Dependence is when you take a drug or substance over and over, and if you stop at something, they're going to have withdrawal symptoms. Not necessarily you're addicted to it, you're not spending your whole life organized around ways to find it and causing harm to your life. I mean, we can put people on medicines for blood pressure like clonidine or antidepressant like Paxil. When we stop these something, people are going to feel kind of crummy for a couple of days. They'll get through it and move on. Opioids are the same way, but much more pronounced. And withdrawal symptoms, we're talking about it, especially with opioids. People are anxious, they're sweaty, they're vomiting, they feel like they have diarrhea, they feel like they're dying, basically. And it can be pretty miserable, and this is what makes it hard for a lot of people just to stop abruptly. And another key term that's important to remember is tolerance, particularly with opioids, why it's a problem is if you take something over and over, people need more of the drug to get the same effect, to get the same result. And this is why I guess I got interested in this and why I care, because people that are abusing opioids tend to use more and more and more, trying to chase the same high or get the same feeling they had. And sometimes it's a fine line between getting what they want and stopping breathing. So the term they prefer is substance use disorder, whether it's opioids, alcohol, but it is something more to make you think more in the terms of this is a person with a condition not that different in some ways from hypertension or diabetes. But the problem is it's potentially fatal if it's not addressed. And I think the hard part to remember a lot of these people and what gets, if somebody's struggling with this and they'll do anything to meet that need. There's more and more research being done on the genetic side of things. We'll see a lot of families where it seems like everybody's got issues. Some of this is behavior you learn, you see your parents using, kids end up using in a lot of cases. But for a lot of studies, they'll show people that are exposed to drugs while they're in utero, while the baby's developing inside the mom, have a much higher risk of developing issues with substances later on. And sometimes it is situational. People are trying to deal with the stress of life, and this is what's available. And somebody says, hey, this is what I use. This is how I deal with my grief. And the other big aspect of how people get into trouble is just what they're using. A lot of things, the big thing about the part of people that get into trouble, these are some common responses. I took a Vicodin once in my life. I crashed a bike, went about 30 miles an hour, and thought I was going to need a skin graft because there was no skin sloughed off. I felt nauseous, was sleepy, never took another one because I did not like how that made me feel. My dad would say the same thing. He had hip surgeries. I'm not taking any of that stuff because I'll get constipated and it makes me feel terrible. But a friend who was a dentist, didn't work around here, but knew years ago, said the first time he took one, first thing he said, wow, I forgot all about the pain. Second thing he noticed, all the problems in his life. He was going through divorce. Suddenly didn't care anymore. None of that mattered. He had that really powerful response, and that's high risk for these kind of people are more likely to get into trouble with it than other people. Some people I've talked to, patients, I just feel like I have energy when I take this stuff. I have to take this to feel normal. Or some people, they're struggling with a lot of anxiety and depression, and it takes away that pain. Specialist, a doctor kind of in Madison kind of described it as most of us have a little bit of a hole in our soul. There's things we deal with in life, but most of us get by. There's a lot of things we actually, I run most days. Some people like to read. There are things that bring enjoyment and kind of bring us to peace. Some people don't have that. They have this big hole and they don't know how to fix it, how to do something in a positive way. And the drugs fill that need for them. And with a lot of the substances, the things that we keep in mind is, especially from the physician end, all these people respond to different things, but there's a pretty good sense that some of the medicines like tramadol, buprenorphine, which is what's in Suboxone, probably less likely to get people that type of response. It doesn't seem to be near as rewarding as you get down the other end. Percocet, oxycodone tend to be more activating the brain to flip those pathways to get people the response that leads to euphoria and gets them into trouble and dependence on it. And an analogy I picked up from another talk was, the drier the tinder, the stronger the flame, the greater risk of fire. Meaning, if somebody's prone to addiction, you give them a drug that's going to more likely to lead to euphoria, get them excited, more likely to get them into trouble. And that's where we need to do a much better job of how we're treating people with not getting them there in the first place. The first exposure sometimes is a gateway to more trouble down the road. Before the 1990s, the thought was traditionally, hey, these things people can be addicted to should really be used only in the most severe cases of pain, cancer, break your leg, fine, short course, get off of them. When I was in med school, though, we had a pharmacology professor who was part of a pain initiative, and found out years later that it was funded by Purdue Pharma, makers of oxycontin. And what they were pushing at that time was that, hey, people can take these medicines, and there's a low risk for addiction. So you do a study and you take people who have that response to opioids, like I had, where it says you get sleepy nauseous, you can say, oh, yeah, these people can use it fairly aggressively and aren't going to have issues. But that didn't really apply to the general population. But they got enough traction and enough drug reps out there really pushing this stuff. American Pain Society got into pushing the idea that pain should be the fifth vital sign. We should assess this with every patient visit. Doctor, if you're not treating pain, you're not treating the patient effectively. And there was concern that, if you're not giving enough pain medicine, you're going to get in trouble. The problem is, it led to what we have today. They didn't have great long-term studies saying how safe these medicines are. And by 2010, you had more people dying from overdose than motor vehicle accidents. And a lot of this started to be used for physicians. They got 85% of misused narcotics still are coming out of physician offices. Hopefully that's going down, but 80% of heroin addicts who overdose, that's where they started. They started with prescription drugs. Either they decided this isn't getting the effect they wanted to move down to heroin, or they couldn't get what they wanted anymore. They got cut off by a doctor, didn't give them the treatment, but instead started buying things off the street. A couple pictures there. Think of Brett Favre. Back after the year they won the Super Bowl in the 90s, he wrote a book with Chris Hobble. It was pretty interesting if anybody's ever read it. He talked about his struggle with addictions, how he got onto it, started using Vicodin, and went from just a few pills for an injury to something he used up to 15, 16, 17 at a time. And just a graphic view of the number of deaths from overdose, how it's gone up in the last decade, and it keeps climbing. And if you compare the accidents, it doesn't match up perfectly, but if you look from 2012, you had 134 people who died from traffic deaths in Wisconsin and compared that to 500 people dying from overdoses of opioids. In 2016, traffic deaths hasn't changed a lot, but opioids, it still keeps marching upwards. In graphic terms, you see the yellow lines, deaths going up, sales of narcotics, the green line going up on the graph on your left from the late 90s up to 2000. Heroin deaths has followed that. And it's a big problem with our heroin epidemic now, and we're seeing it here. People either graduated from prescription narcotics, couldn't get them as easily. Heroin's dirt cheap, and it's incredibly euphoric feeling. And unfortunately, how much you guys, the police officers, you've seen out there, but more and more people I've talked to, it's a real problem. But the question is, how do we solve it? I mean, this isn't really should be rocket science. The Americans seem to have this idea we've got to come up with a new way to do everything. But if you look at Europe, they had a huge heroin epidemic that kind of preceded ours in the 1990s. And they have some very successful initiatives that really cut down use and, more importantly, cut down overdose rates. We don't need to reinvent the wheel here. We've got things that can work and can help people. It's just a matter of using it. Portugal is an example. In the 90s, they had over 100,000 people that were addicted to heroin, and their death rates were skyrocketing. Instead of trying to criminalize everything and throw up the legal system, throwing users in jail, we took more of an approach, we're going to prosecute the dealers. What's petty, the small end dealers and people using, we're going to try to get them into treatment, to address the addiction. And the use fell by over 70% over the next decade, and more importantly, overdose deaths fell. If you compare that to Wisconsin, Portugal is a nation of about 10 million people. Wisconsin's just under 6 million. In 2016, we had 817 people die from overdoses. They're down to 27 people who died of overdoses in 2016. So these efforts can make a big difference with folks getting into treatment, getting people the help they need, and trying to emphasize more of a treatment prevention model than just we're not going to incarcerate our way out of this. Too often, physicians take the easy way out. So, you sprained your ankle, here's some Vicodin. It's like, time out. Sprained your ankle, you probably don't need a bunch of narcotics. Maybe we need the, more education people. You need to ice, elevate, rest, use compression wrap, but you can survive this without narcotics. People with chronic pain, instead of continuing narcotics forever, and studies have shown that this really isn't effective in treating it. It's looking at what else can we do for people. People can use, we gave a talk a couple of years ago at the casino about how else we treat pain. And there's so many modalities out there, things we can do if we think outside of the box, from getting people to do yoga, Tai Chi, getting people into physical therapy, using chiropractic care, using acupuncture, using other medications that may be helpful, but bottom line is a lot of pain, it really is educating people. Pain is part of life, and how can we address this effectively, fairly, but keep people healthy, moving better, feeling better, and without putting the risk for this. Because a big part too is, if you're giving somebody, chronic narcotics for whatever condition, it's sitting around at home. What happens when the teenager's over? What happens when the kids get a hold of it? The temptation is to share it with other people, for people to take it, and it's become a huge, huge problem. And when we get into treatment, when we're trying to emphasize what they recommend, the big two components for people with opioid abuse disorder is getting them into behavioral therapy. The medication is really a small part, it's a big part of how can we work with people to learn, to retrain their brain essentially. When you're using these for a long time, people lose the ability to secrete those neurotransmitters. They need to feel normal, to function normal, because they're relying on the drugs more and more to do that. And it takes a long time to get that circuitry back up and working. And if we can get them to learn ways to build self-control, self-esteem, getting new circles of people that they're going to be associating with, hopefully we can reduce the risk of them relapsing, but also meeting the needs they have. Because a lot of people are suffering with anxiety and depression, and how can we treat that better? How can we treat them as a whole person, not just as one issue in their life? And using medication-assisted therapy really, the Society of Addiction Medicine really does. It should be the gold standard of how do we address patients. Maybe it isn't the right thing for everybody, but for a lot of people that are going to do better using medicine to get through this. Because it can help with the initial withdrawal symptoms like that. It's pretty amazing we started doing this. You have people who come in looking like they're half dead. They're just about to crawl on the walls because they're going through withdrawal. It's pretty amazing where you can give them a small dose of Suboxone, and that quiets down, and suddenly they can sit down and have a rational conversation with you. But it really is, it's a bridge to sobriety. It's not the overall cure. I wish it was, where you take this one pill and you're done, you're never going to need anything else. But it's the first step. But it definitely is said to show improve outcomes. And the goal really is the full recovery. But it's a long process to get people there. But as far as the other big issue is being able to try to put people's lives back together, get the people who aren't working or need to hold down a job, get them back to work. And that's been one of the encouraging things. It seems like a lot of the people that we've had success with, they're back to work, they're taking care of their kids. Some people that are at risk of losing their kids are able to be a functional parent. It takes time to rebuild those relationships with their family members, but hopefully we give them the space to do it. And the one area that we probably need to do more of is for some of our pregnant women. Because the studies show definitely women who abuse opioids are higher risk for relapsing, even if you can get them to quit. A lot of them want to quit because they're pregnant, but they're more risk. If something stressful happens, they start using again. And if it's not just opioids, a lot of them can't get that. But meth, cocaine, things are even more risky potentially in a pregnancy. But instead of show people, women, you can get them on medication is through the pregnancy. The higher birth weight infants are less likely to have complications related to it, and hopefully a chance to be a better parent down the road. The relapse rates are pretty high across the board. ASAB estimates that just the old traditional 12-step programs, abstinence-based program approach, where you get people off, you get them through withdrawal, and you just work on a behavioral approach. As many as 90% of people are going to fail within a year in relapse. I was at a conference this fall where the head of the Hazelton Center in Minnesota, Mr. Moyer, spoke about his experience with addiction, but also how they went through the change of the traditional abstinence-only approach to when they started using Suboxone with the patients there, because it's simply, you've seen too many people die. They'd leave, they'd be saying, I'm doing great, I'm ready for the world, and boom, they'd have 70, 80% of people, 90% relapse in a year, and a high percentage of them die. Because when you stop using opioids, and you can get people off, but get through this withdrawal things, they're doing great, but those cravings start kicking in, they're more likely to use, they start remembering, well, I used this much before, I'm fine. But when they stop, you lose that tolerance you develop for. So suddenly, where you needed a dose of fear to get that effect, that's going to kill them. But if people relapse, it's more likely to end up in jail and end up with contracting diseases, especially if we're seeing more heroin. We see a lot of people inhaling it, probably less risky than people injecting it, but we're seeing a lot of people with injection drugs, which leads to a lot of potential problems from risk of hepatitis C being spread. We haven't had a lot of HIV issues here, but if we see this heroin use continue like it is, we're going to probably start seeing that before long. And that's a whole other set of problems. And that's where you get into the risk reduction, harm reduction model of, what can we do if people are going to use, how do you make sure they have safe needles? How do you make sure you're doing things as safely as possible? That doesn't eliminate it, but hopefully can help save a life. You got people that have had severe infections when they're injecting, and one gal who's lucky to not lost her arm. You see people who just like injecting feet because you can't see the track marks there. Feet's probably the worst place to inject somebody because you're tons of bacteria on our feet, and if you're just trying to get that in as quick as possible, you're not doing it sterilely. So it's a lot of work to try to get people to prevent them from getting into this trouble, get them out of the cycle. But the studies, there was at Mayo for a conference as well, and they started with a third of your patients are going to fail if you start with medication-assisted therapy, which sounds pretty crappy. But when you think about it, it's still a much higher risk chance of succeeding than if they're doing just a traditional abstinence-only approach. They're more likely, like I said, to get them back and to reconnect the family, get on with their lives, and hopefully some sort of a normal life. If we think of it in terms of conditions like diabetes, I've been here for 17 years, taking care of a lot of people with diabetes and hypertension. I can think of maybe 2 people that I'm able to add on medicine, got them to turn their life around, get off medicine and do well. But it's a chronic condition that needs to be addressed, and it's for these folks as well, even if we can eventually get them off the buprenorphine, they need to keep working on things in life. It's With diabetes, you can exercise, you can eat right, and you can get your sugars down and do well, maybe you don't need medicine. But if you don't keep doing that, keep working at it, you're going to get into trouble, and it's going to come back. And it's the same thing with these folks, is getting them through there to believe this counseling, the skills they need, sort of less likely to relapse. And it's in the convince them that, yeah, this is the thing I need to work on my whole life. Just a little bit into how these medicines actually work. Key concepts with that is your traditional opioids, like you take oxycodone, hydrocodone, they are full agonists, meaning they bind to these receptors in the brain. Primarily, it's called the mu opioid receptor. And when it hits those receptors, that's what creates the response people like. It blunts pain, but also makes people feel good about this. You get this endorphin release that makes people forget about the pain and everything else bad in the world. The flip side is antagonists are things like naloxone, where if somebody has an opioid overdose, you can give somebody that and you reverse the effects of the opioid agonist. Suboxone is a partial agonist. Antagonist means it partially binds those receptors, the mu opioid receptors, but it also blocks them, meaning it can get on there and get onto those receptors in the brain, but it can also displace other things on board, which is why when we start somebody on it, you need to have them starting to go through mild withdrawal symptoms. When somebody just takes heroin that comes in and you put them on the Suboxone, you're going to precipitate withdrawal symptoms because it's powerful enough that it can kick those receptors in the brain. What works nice about it and why it's not as reinforcing as the drugs that people tend to abuse is that it binds those receptors and it stays on there a lot longer than, say, like a Percocet, which hits it and wears off and people wanting it again. And there's people that have come to me that are said, yeah, I bought Suboxone strips from some people in the community, and we've seen reports where people are posting online that they're selling strips when they're coming back to the centers elsewhere. But it's usually people who are buying, if they do buy these things, it's not that they're feeling good about it. You have to find somebody who says, boy, I feel great when I take that. It's more, I was trying to quit and not feel terrible. And as far as the medicines, when you talk about medication-assisted therapy, we're using the buprenorphine naloxone combination. And I'm right now the only one who can prescribe it in the clinic. You have to do a special training course to do it. Sue Wiso is completing the process, so she's going to have a waiver, so that means with some backup on it. It's been increasing. We're getting more and more calls and trying to with behavioral health capacity we have. How can we expand that service so we can get more people the treatment they need, but also get quality services where they're hopefully getting the skills they need to improve their lives and be less likely to relapse. Right now, we're starting with a model where we'd have people see behavioral health in our clinic for one-on-one sessions and starting with one appointment a week. Problem is, we have a limited number of people there, and if you start figuring if somebody's spending an hour with a therapist a week, how many patients can they take in, plus everything else they have to deal with. There's some people who have a great support network at home. Nobody at home uses, they've got family members who are helping them out. They probably are less likely to need the traditional support group than, say, somebody whose spouse uses or their people they live with are still using or dealing, because they need to give them the best chance of success. They need to establish new relationships with people who aren't using or less likely to get them back into trouble. Methadone, before there's buprenorphine, was something that's commonly used for narcotic addiction. The problem is, you have to be in a licensed treatment center to use this. We can't do methadone practically here, but it's a medicine that can work really well, especially for people that are really hardcore users, people that are heavy use, higher end users who maybe end up needing to be in a program like this. There, they have to travel there once a day. Eventually, they can earn privileges, or maybe they'll take it home once on the weekend, sometimes a little longer. But the concern with methadone is, and why it's more tightly controlled, is it's a full agonist of those opioid receptors, and if you use it, some of these people are on 120, 200 milligrams of methadone a day. And if any of us in this room who's not using narcotics takes that, or even a fraction of that, it's a high risk of overdosing and dying. And naltrexone's a third option, which if you got somebody who's had a long period of abstinence, meaning they've been in jail or a treatment center, they're coming out, is a third option. It's not a narcotic. It's a pure blocker of those opioid receptors. For some people that have bad liver problems, especially if they've had alcohol use issues, you got to be a little careful with that. We do use this. We have a number of patients on it. The problem is the trick is getting people to come back regularly and follow up on it. Some people say, oh, I've been on a month or two, I'm fine, I don't need this anymore. And when you stop, they go back to using it again. There's a higher risk of overdosing because they go back to using doses similar to what they used before because they lose the tolerance. It's certainly better than turning somebody loose without anything. Some people we've talked about is we're weaning them down in this box, or maybe using this as the next step to give them a little more support to extend things out. But it's definitely you want people into counseling, and it's not just that you're one shot and you're cured, which some people want to think it is. But it definitely can work well. There's some jurisdictions where judges are requiring people to be on this in terms of their parole. I think that's maybe reasonable for some high-risk individuals to try to reduce the risk of relapsing. And if you can tie it to the mandatory having to come in and get the injections and not getting lost to follow-up. But so just to finish up with specifically what we've done, I've started in 2017 is when we finally started using Suboxone with patients here. As of a couple weeks ago, we had 36 patients start, and 23 are still with us. So it's about average of what they predict. About 2/3 of the patients doing reasonably well on it. A third of them have fallen by the wayside. Of the 13 that left, what's interesting, a couple of them did get incarcerated, so they kind of dropped off from that. And it's just, it's a nationwide debate. What do you do with people who are on these things and they get thrown into jail? The advocates from the Addiction Society say, that you really should, keep people on these medicines because the risk, especially if they're short term, there's a high risk of when you're going to get out maybe a week or two later, then suddenly, boom, they had nothing to do for a couple of weeks, but what am I going to do to get rid of this feeling? Because you stop somebody suddenly on it, you will go through withdrawal symptoms, and you get through that short period of time, but then there's a risk for relapsing. We had a couple of people who went to jail. One was great. She went in, did her time, came back, we got her back on it. The jail here was good with working with us, so they kind of beat it down, so it wasn't an abrupt stop. And that it's probably, if you're not going to keep them on while they're in jail, if you can slowly wean them down, people are going to do much better than if you stop them abruptly. Because you stop any of the things abruptly, you're going to go through withdrawal symptoms. We've had 8 people that say, this just isn't for me, I'm not ready for it. Some are doing well. A couple of them, they had issues where they weren't meeting the rules of the program, weren't following up with behavioral health. Said, I can do this on my own. Realize they can't, and help them get into other programs. Which for some people, maybe they do need the more structure, going to Appleton or Green Bay, or going down to over to Wausau once a day. And for some people, they definitely need that. We did have one person who left, who went to a methadone program for a while, and it didn't end up well. She relapsed and died. And that's what we're trying to prevent. You can't save everybody, but hopefully we can save some people. And it's, we talk to the people who are doing well. It's definitely made a difference as far as for getting their lives back in order. And these are the harder things to get numbers on and to quantify, but if you think of people that are there for their children, being part of the kids' lives, where before, imagine having a parent who's abusing substances. They're either high and don't care, or they're grouchy, miserable because they're going through withdrawal, trying to know where they're going to get the next hit from. And it's one that you can't be there for your kids if you're living that kind of life. Same thing is, it's hard to hold a job down if you're struggling with abuse. And money goes there, and you get a drug screen and workroom, and you're out the door. So we can keep people working, being there for their kids, repairing relationships with their family that they've poisoned over the years. The hope is to make a difference in the community. And one thing we've definitely seen, people doing well tend to bring other people in. As, they've got several people that have brought in cousins, co-workers, things that the hope is that they could be that positive influence and be a change in the community we need to see. So, I guess we've got a couple minutes if anybody has any questions or more details on what we've been doing.
I have a question. Was there anything in place for I used to work in the pharmacy actually, and there would be a lot of people that would call to try to get their meds refilled early. Like after 2 weeks after they just got them filled, they'd call 2 weeks later and try to get them filled.
Yeah.
And I don't know if they started flagging people or the doctors reach out to them and see what's going on if you're getting, addicted or family misusing them or anything?
I mean, that's supposed to be, the policy now is if you're given, not especially a month's worth or a week's worth, whatever it is, that you can't get early refills on things. There are no excuses. If it's lost, stolen, police report, no police report, we can't replace these things. If you're using it inappropriately, we need to get you back in to see it. But it's kind of like, I always think of in terms of, if you always give your kids everything that they want, you're not probably helping them a lot of times. One of my kids, if she could have ice cream for every meal, that would be, you're the best dad ever, but you'd probably end up in court for child neglect pretty soon if you're just feeding them ice cream. But it's, I hate to be paternalistic in that, but it's always, if you have a controlled substance, you got to bring your ID to pick it up. Only certain people can pick it up. You can't have 6 family members, calling in with a race of who can get this medicine first, and then it never gets to grandpa because they're fighting about who can grab it and convert it coming out of the pharmacy. So it's a struggle. With the Suboxone patients, they've got to have their ID. They've got to pick it up. If there's something where somebody's hung up a work with rare circumstances, we can make some occasional adjustments for that to be humane, but by and large, you're not filling it early, you're not picking things up for other people, because you don't want it to disappear into the wrong hands. And we need to do a better job with all of our controlled substances like that, for all the narcotics, the anxiety medicines, the gabapentin, all those things.
No other questions? Thank you, Dr. Gunther.
It is so nice to see this many people here today. Just thank all of you for coming. This is a topic that touches all of us, that's for sure, in our community. So, from the bottom of all of our hearts at the clinic, thank you for showing up and listening to us and the great questions and conversation. So my name is Diane. My official title at the clinic is Behavioral Health Care Coordinator. But today I'm going to talk to you about Good Drugs Gone Bad. And this is a curriculum that is throughout the whole state of Wisconsin. I changed it up a little bit for us today because a lot of slides duplicated what Dr. Gunther just talked about. So we're going to talk a little bit about the dangers of opioids and what we're seeing around the state. And then we're also going to talk about all the different things that we have going on at the tribal clinic to offer our patients as an alternative or a different option to just giving them the pain medications. So this is kind of 2 little different presentations here today. But first of all, we're going to talk about drugs. We're going to talk about the good drugs gone bad. And a drug is a substance that changes the way our brain and body function. And drugs can be very, very helpful, right? I'm sure there's a lot of us in this room and family members that continue to maintain good health in our life because we do have medications that can help us with our blood pressure or heart disease or cancer. And so there are really good reasons that people do take drugs. And there are real good reasons that we do have to prescribe pain medication, most days at the clinic as well. So the types of drugs. There's legal drugs. We're probably all, guilty of that first one, caffeine, different sort of things we can buy over the counter for colds, vitamins, headaches, different things like that. But this is something that we can all get our hands on legally. The next class of drugs are legal for adults only. And in our state, that includes nicotine and alcohol. And finally, there are illegal drugs. And those are the things like marijuana, cocaine, and heroin. And what we're going to talk about today are these opioids. They started off as just a prescription drug. And like I said, there was really good reason that they were often given out. And through years and years of experience, we have found out how very dangerous they are. So they kind of went from being just a prescribed drug to kind of on the bottom, to being an illegal drug, because people were getting their hands on them for all the wrong reasons, and people were, going to pretty good extremes, stealing, lying, cheating, to get their hands on those medications. So what are we facing? Right now, biggest opioid crisis that we have seen in our nation. For the first time, Unintentional overdoses have replaced car accidents as the number one death. And this slide says 15 states and the District of Columbia, as you can see, this slide is about 9 years old. It is the vast majority of states now. A Wisconsin problem. You know, we are in the same nation. There are enough controlled substances prescribed in the state of Wisconsin that we can medicate every single citizen in the state of Wisconsin around the clock for 40 straight days. That is a lot of pharmaceuticals being out on the street.
Brilliant police are tonight investigating 2 possible drug overdose cases, one deadly, they believe could be related. Police say a 30-year-old man they found passed out at home was taken to a hospital. Then this morning, police say they found a 28-year-old man dead outside his family's residence. Officers say both men were with a third person last night, and so they're interviewing that third person to try to find out what may have happened to both men. Police say both men took prescription drugs. Drug abuse has long been a problem for young people in northeast Wisconsin, and not just street drugs like heroin and cocaine, but also the abuse of prescription drugs.
And a federal report last year indicated that 15% of high school seniors say they had raided a medicine cabinet and abused a prescription drug within the previous year. Fox 11's Ryan Dietz takes a closer look at what officials are doing to keep kids' hands off your pill bottles.
He never got to learn from his mistake.
Karen Falk knows all about prescription drugs. That's because her son, Corey McNeil, died of an overdose almost 3 years ago.
These kids need to understand that messing with this stuff is only tragedy can happen. I mean, even if it doesn't kill you, it can certainly ruin your life.
Most people know about the dangers of marijuana and cocaine, but how about what's in your medicine cabinet? It's stories like Falk's that have law enforcement agencies kicking off their Good Drugs Gone Bad campaigns to raise awareness about the abuse of prescription drugs.
This is a serial killer that we need to take off the streets.
This is 1 year of drugs confiscated from places where deaths have occurred. Officials say it's important to keep drugs like this away from teenagers.
Lock up your prescription drugs. Keep it away from the kids.
That bottle is not safe in your medicine cabinet. It needs to be locked up. It needs to be put away. Keep the drugs away. Make them, at least if they're going to have them, make them work for them.
State legislation is in the works to create a registry of when and who buys a prescription to crack down on what pill abusers can get their hands on, and also to give parents like Karen Falk some peace of mind. In the town of Menasha, Ryan Dietz, Fox 11 News.
Officials also encourage you to bring your extra prescriptions to a local pharmacy where pills can be properly thrown away. You can find that information on our website, fox11online.com.
So the abuse of prescription drugs. When prescription drugs are used for a non-medical purpose, a purpose other than which they were prescribed, that is abuse. So it can be that the medication is even prescribed to me, but I'm using it in a way bigger dose, than intended. It could be that they were prescribed to me to swallow 1 pill every 6 hours, but I'm crushing them and snorting them, or I'm heating them and injecting them. So that is drug abuse as well. So it could be for the person that they're prescribed to, and it can also be taking someone else's medication. And it is abuse, and it is illegal to take someone else's medication. So how many prescriptions are filled every month in Wisconsin? What do we think? 5 million prescriptions filled in the state of Wisconsin every month. So prescription drugs, they are meant to be safe and effective when we are taking our own medication exactly as prescribed. People do lead healthier lives because of their prescription, and many lives are saved because of prescription drugs. So a few myths and facts about prescription drugs. Drugs are safe when they come from a doctor, right? We know our doctors, they wouldn't prescribe us something that's going to hurt us. That's kind of the myth behind there. The facts are prescription drugs, that they're not taken responsibly or as your doctor prescribed, And it says, can lead you into the emergency room or even the morgue. Another myth. It's okay for me to take prescription that was prescribed for my family. You know, so my brother falls down and breaks his leg, and the next week I've got a backache, and he says, well, these are safe. You know, the doctor gave them to me. Here, I'll just give you one of these. You know, again, a very, very bad idea. A medication, they're prescribed to us based on many different things. First of all, other medications that we might take, right? Just because it was safe for my brother, I may be on a medication that is really going to interact with that. It's based on people's age, their size and weight, and also other medical conditions that you may have. So it is never, ever safe to take someone else's medication. In fact, they are extremely addicting. As Dr. Gunther and Jared were talking about just a little while ago, you know, sadly, we are finding out exactly how addictive these medications are. They cause death by simply slowing down and stopping our breathing. You know, we've all been through our teens and 20s. We've all seen people who had too much to drink, right? And, you know, you can tell they maybe start vomiting. And we know, you know, we've got to get them some help. We've got to keep them up. We've got to keep them talking, things like that. This happens quickly and silently. You could be right next to a person where this was happening, sleeping right next to someone, and not even know that this was going to happen. Prescription drugs can slow our heartbeat. They can cause seizures. We saw that in a lot of our community with ISH, right? How you know, different sorts of drugs can cause seizures. And finally, it can halt bone growth, cause liver tumors, other cancers in our body.
This kid died from using illegal drugs. And this kid died from using prescription painkillers. Now you tell me, which one's more dead? Talk to your kids about prescription drug abuse.
So more consequences of drug use, addiction. You know, the addiction is no different when you are hooked on prescription drugs than it is being hooked on any other illicit drug or alcohol. Loss of friends. And this kind of goes both ways, right? We know that the people that we help every day, sometimes we actually have to ask them to find a whole new circle of friends. So, you know, when Dr. Gunther was talking before, how people are getting on with their life and leading more productive life, sometimes this meant leaving friends and sometimes even family members behind because they were not supportive of their sobriety. Families torn apart. We are seeing abuse and neglect of children like we never have before over this prescription drug epidemic. Addicts' addiction is very, very selfish. Money that should be going to food and clothing and things for the family are now being spent on drugs. When someone who's addicted to opioids wakes up in the morning, the first thought that they have is, how am I going to get these drugs? Where am I going to get them? How am I going to find money for them? It doesn't always matter if they can't feed their addiction. It doesn't matter how their child's getting to school. If that child has breakfast, if it had a bath, you know, any of those things. We have children being raised in environments where all the adults are impaired. You know, they're not making the best of decisions for their family. So this opioid epidemic, you know, although unfortunately we have always had some problems with child abuse and neglect, it has really gotten to the point that we have not seen before. Loss of jobs, being, you know, asked to leave school, either, you know, high school and college. But yes, a lot of people right now losing their job, their home, everything, you know, because this addiction can get so expensive. Court involvement, of course, oftentimes the court's involved. And again, for the families, not enough money for other things. We have had so many patients, we have heard of stories, you know, that they were stealing from their family members. that they are now starting, to repair those ties, because they will do anything to get their hands on these drugs. And that means sometimes stealing in line from those that are even closest to us. So in Wisconsin, 60% of our teens report that they have access to controlled substances in or around their homes. So every year we go into the schools and we do ask kids how accessible these substances are to them. They're pretty much telling us that they can find these sort of medications pretty much daily. So is there a problem? Right now in the Fox Cities, hour away, #1 problem, drug threat in that community is prescription drugs. Prescription medications are involved in 70% of overdose deaths in southeastern Wisconsin. So yes, in our state, in our area, in our little teeny community, this is a huge problem. So the danger, this is a real danger. Please do not let anyone fool you that messing around with prescription drugs is not dangerous. It is extremely dangerous. Every day, 2,500 teens experiment with prescription drugs for the first time. That's a lot of kids. So how are they getting their hands on these things? Look at this, 70% obtained from a friend or relative. They are helping themselves to grandma's medicine cabinet. They are getting into mom's purse. They know dad keeps things in the car, in the glove compartment. So friends are helping each other. They're trading for these things. So very, very small amount bought from a drug dealer, 4%. This is changing the dynamic a little bit. From one doctor, 19%. A lot of doctor shopping going on. A lot of people trying to find multiple ways. They're going to the doctor, then they'll turn around and go to the emergency room, then they'll turn around and go to the dentist. They're spending a whole lot of time and resources trying to get their hands on prescription drugs. What the state of Wisconsin and nearly every other state has now done is when our doctors here and everywhere else across the state write a prescription for any sort of scheduled medication, and that is a pain medication, certain sorts of ADHD medications, and also other kinds of sedative type drugs. You have to go on the state registry and you need to put in there that that person is getting that medication. So if I was at the clinic today, and now tonight, I'm trying to get to the emergency room, or next week I go to a different hospital, they can look up my name on this. It's called the Prescription Drug Monitoring Program, the PDMP, and they can see exactly how many prescriptions I have gotten. So the nation as a whole is doing a pretty good job as far as this doctor shopping. This was a huge problem a few years ago, and now this is getting a whole lot better. So things that we're seeing as a state, ways that people are getting their hands on prescription drugs. Open houses. We see realtors doing that all the time, right? You're basically opening your house to any stranger to come through in hopes of selling it. They are now warning people, get your prescriptions out of your home before that. We have people that would instantly go into open houses, run right to the bathroom, right to a medicine cabinet, right? They're looking around for these things. Sleepovers. We're a very small community. We know who just fell and broke their leg, who just had surgery, who may be going through some difficult cancer treatment. We know that, right? These teens are really crafty. If you've got teens in your home, make sure your medication is locked up. Come right to this facility right here. They'll give you a lockbox to do that. Emergency room visits, we just kind of talked about that. People asking, can they get into your home? Strangers plain darn stopping and asking, if they can use the bathroom. Obituaries. How often do we see in an obituary that so-and-so passed away after a lengthy illness? guess what is associated with a lengthy illness, right? A lot of prescriptions. So get them out. You know, we'll show you where the disposal box is in a couple slides down the road. Burglaries and thefts. I had a video game system stole from my house a couple of years ago, right? And no big deal. They came in, they left everything alone, nothing else was touched, no jewelry, nothing. Came in, got the video game system left. The cops came over, the first thing they asked me, what prescriptions drugs do you have in your home? And I kind of looked at them, I was really taken off guard. And they said, normally, that's why people are coming in. We didn't have any, so there were none stolen. But, you know, that was a really huge eye-opener for me. You know, my goodness. So what is being abused? What we've been talking about to this point are those pain relievers. If we look down on the bottom, morphine chemically is very, very close to heroin. Chemically, they're near identical. So when the prescription drugs get too hard to get, when they get too expensive, what happens is these people make this turn to heroin. And unfortunately, we are seeing that right here in our community. And oftentimes when you do talk to someone who is addicted to heroin, they will say to us, yeah, this started because, you know, I was in a car accident, or I fell and broke my leg, or whatever. I was at a training one time, and you know, oftentimes we'll hear people say, you know, yeah, I'm gonna try it, but I'm never gonna inject, right? I was at a training that said the average time between someone's first use of heroin and injecting heroin is 2 weeks. That's a really short window of time, right? So people are just always chasing that bigger high, that bigger high, that bigger high. And so it is a progression. Stimulants, these are the drugs that we use for attention deficit disorder. We've gotten really good in our community about this too. Almost all of the children that we prescribe these to at the clinic, we work with the school. We have the nurse, the social workers, the guidance counselors coming right to clinic, picking up those medications and dispensing them daily at the schools. So oftentimes these medications are not going home. We were hearing different stories, you know, asking kids, you know, teachers are saying we're not seeing any behavior changes, right? This child is not responding to their meds. And we asked the child, did you take your medicine today? Well, I don't take any medicine. You know, parents were getting their hands on these medications. So we have bypassed parents in a lot of the situations, and a lot of the kids in our community are on these medications only 5 days a week when they need, you know, to really concentrate at school. Most of them have the summers off. They take, you know, little Ritalin vacations. And our final choice of category of drug that can be abused are the sedatives and tranquilizers. We don't see a whole lot of this here. I mean, maybe law enforcement or Nick later is going to talk what we're seeing on the EMT calls. We don't hear a lot about this at the clinic, I should say. And when we do hear about this, people are using them for the reason that's intended, right? They just got very overwhelmed. They needed to sleep for a few days. They just, you know, had enough. So usually when people try to get their hands on these aren't real fun, right? If any of us have had to take these medications for different things we have had, you know, they kind of just knock you out. So why are people abusing prescription drugs? You know, we just mentioned heroin a little bit ago. What's the stigma attached to heroin, right? I mean, when we think of the heroin addict, we think of that back row junkie, you know, and that's not the case anymore. Opioid addiction is prevalent in every race, you know, sex, income level, educational level, it is out there. But when we're talking about the drugs, abusing prescription drugs, first of all, they're easy to get, right? We just saw the little boy or the teenager take them right out of mom's purse. Our friends are doing it. Kids are getting together and taking sometimes things they don't even know what they're taking. They'll put them in a great big bowl and they each take a little handful. I mean, that sounds so terribly scary to me. People self-medicate a lot, right? A lot of pain in our community. They find if they can just shut it off a little bit. And that's why we put the counseling in place at the clinic. You know, we know that somebody doesn't wake up one day and decide, hey, I think it'd be really good to be addicted. We know that there's a lot of pain in these people's life, and there's a lot of things that these folks have to really kind of talk about. And finally, a little less stigma, right? A little less stigma to say, hey, you know, yeah, sometimes I take a little too much Vicodin versus I'm a heroin addict. So people mistakenly believe that abuse of prescription drugs is less dangerous because they're prescribed to a doctor. They have fewer side effects and they can share. And believe me, we hear every day at the clinic about people sharing their medications. People have kind of a weird notion now that when they go to the doctor, they need to get a prescription, right? They don't feel like anything's been done. Oh, they're not listening to me. I didn't get those antibiotics, or I didn't get that pain medication. You know, people really want to get medication when they come into the doctor. And they want the quick fix, right? We're going to talk a little bit about all the things that the clinic has going on, but that's not always the quick fix, right? You know, take a pill or go to 10 physical therapy sessions. People want the pill. It's instant. It can make them feel better right away. All the drug commercials that we see when we turn on the TV, right? We see them every day. Our kids are seeing them. My son is a very little boy. I have a lot of allergies. Told me that he could get a cat because I could get Zyrtec. And I'm like, hey, Zyrtec? I said, what? How did you know about Zyrtec? He saw the commercial. You know, so he had this all figured out. Mom can get some meds, I can get a kitty. You know, and it's like, no, that is not how this works. So, 1 in 5 teens reported that their parents never talked to them about illicit drug use or alcohol use, right? Because we've all done that. We've all talked to our teens, the dangers of drinking and driving, you know, to get out of people's homes if there's drug abuse going on, you know, whatever and ever. Have the teens say their parents have never talked to them about the dangers of prescription drugs. So please, let's have that conversation with our kids, right? Let them know how dangerous that these medications can really be. So for the most part, like we saw on the pie chart before, most pharmaceuticals that are floating around in our community have come from a legal source. They were someone's prescription, right? They're selling them, they're stealing them, whatever the case is. So we're asking our patients, be attentive when you go to the pharmacy. You know, we moved the pharmacy. Remember when you walked into the tribal clinics first, you walked in the front door and there was the pharmacy? We would get calls probably on a weekly basis that they would see people right across the street exchanging pills or people giving away their pills. You know, we put the pharmacy, it's a little harder to access now. When you talk to the pharmacist, you're off to the side, you're not right out in the open where everyone can hear, okay, Diane, you know, here are your Percocets, you take these, you know, 1 every 6 hours. When you're leaving the pharmacy, put those pills away. You know, if you've got a purse, or now we've got winter jackets and things, put them in your pockets or your purse or something. Don't just go walking out in the parking lot, you know, with that little white bag from the pharmacy, because people will and do stop our patients at times and ask them. So, you know, be aware of what's going on. Don't let people know when you have these sort of medications in your possession. So, legitimate reasons for prescriptions. Pain medication. One of the most painful things are fractures, right? A lot of us in this room have had fractures. There is no reason that someone needs to put up with that sort of pain, right? Dental procedures, different injuries, post-surgical. But those, when we get medications for those, those are usually pretty short-lived, right? A few weeks maybe, get us over the hump, get us healing enough. But there are also some reasons that people use them long-term. Over 3 months, we call that chronic pain. In our little community, we have a lot of accidents due to forestry. And sometimes these are really traumatic accidents, right? They fall, trees fall on people's backs, people fall from high heights and things. And so we know sometimes that people do have to be on these medications. If you are on a pain medication, at least from the tribal clinic, for 3 months or longer, we are going to ask you to sign what is called a narcotic agreement. And I'm going to show you a couple of things. The agreement itself contains almost 20 things. We're not going to go over every single one, but this is basically what these folks are signing. This is what it looks like. Number one, we're going to start using this to treat your pain as a last resort. If you've got a fracture, no. But if this is going to be a chronic thing, we're going to ask you to do other sorts of treatment first. You have to understand that we cannot take all your pain away. And number three, understand narcotics are addicting and can cause death. Our patients need to sign this to get those medications. Know that this medication can cause slowness of breathing, delay reaction time. Number five, know that I may become dependent on these medications, and to stop them, they may need to go through withdrawal. So we are educating our patients. Sometimes, like I said, this is the last resort. People might not be able to function without them, but they do know the dangers going in. So this graph is a little hard to see, but it basically says for every death of a person, there are 10 people that are getting treatment. There are 32 that are visiting the emergency room. There are 130 people who are addicted. And there are 825 people who are just occasionally using this. So for every one death, and unfortunately in our community, we've had a lot of deaths lately. So if we would multiply all those deaths and understand that for each one of those deaths, there were over 800 other people experimenting with these drugs. That is a very scary statistic. So why are pain pills so addicting? And Dr. Gunther talked about this. Mine uses a lot, easier words to understand. But basically, there are certain feel-good chemicals and things in our body that are released. And we could get that. We could get our bodies to naturally do that. You'll hear people talking about runner's high sometimes, right? Like if a runner like sprains or strains something and can't run for a few days, how terribly miserable they are. They feel awful when they can't do that. But no amount of exercise can put out the endorphins that these pain medications do. And how do pain medications cause death? We've already talked about this a little more, we're always experimenting on the next biggest dose, right? The next biggest dose. And we're going to talk a little bit later in the day about Narcan. One of our EMTs is here with us today. And although Narcan is a great thing and it saves many lives, sometimes people are now even pushing experimenting to the extreme limit because they know that Narcan is available, right? So people are chasing that high. And like Dr. Gunther said, sometimes, we will get people in treatment or we will have to incarcerate them. And maybe they've been off of drugs for a couple of months. And they come back out on the street and they use that dose that they were at a few months ago. And that is extremely dangerous. That would be enough to kill somebody. So safeguard your pills, please. If you have these medications at home, if you have any medications at home with young children and teens at your house, know how many pills you should have. You don't have to count your meds every day, but and we all mess up on taking our meds once in a while, right? We don't remember, oh my gosh, did I take that this morning? Sometimes we take 0, sometimes we take 2, but no. And please dispose of medications that are not being used in your home. If, you know, that condition got better, you have medication left, or that prescription gave you an upset stomach, so you had to get a new one, or someone in your household dies or has to go to the hospital, you know, please get rid of that old medication. So legal troubles. Selling, sharing, giving, misusing even your own medication is illegal. It is now going to get you in legal trouble. So we take that very, very serious at the clinic. If we find that someone is diverting their medication, if I've got 60 pills and all of a sudden, you know, if someone calls me in to do a drug screen or a random pill count, if they hear that I might be sharing those, and we can do that. Anybody who is on our medically assisted treatment program or anyone that signed a contract like you just saw, we can say, you've got today to come down to the clinic. You know, we'll have you give us a urine sample and we will count your pills, or we'll count your Suboxone strips. And they all better be there and be accounted for, right? It's a really, really good way to lose your privileges to either get your chronic pain medication or your medically assisted treatment. We try very, very hard to stop the diversion in our community. So where you can get rid of those unwanted medications. You walk into the police department, you walk in the front door, it's right off to the side. When you go during normal police office, you know, when the front window is open, there is absolutely no questions. You walk in, you put it in there. No questions asked. If it's after hours, you are going to need to tell them, I want to use the drop box. But again, they're not going to be asking you, why, what do you have? Why do you have them? You know, when you're there getting rid of them. So please use this. So finally, what we're going to talk about today are the alternatives that we have going on in our clinic. And when you see some of this stuff, we are so fortunate. You know, we have leadership in our community that recognizes, you know, that it isn't all just Western medicine that's going to work. We've got a lot of different alternatives. So, you know, we couldn't just crack down and tell people, no, you cannot have pain medication, because we know people have pain, right? I mean, we can't just say it's perfectly okay to have pain. So we went and kind of looked, you know, outside the typical box and say, what can we do for our patients that can give them some pain relief without all of these medications? So we are, again, first line in our narcotic contract, that the pills are going to be the last resort to treat your pain. And do not expect to be pain-free, right? That is not the goal. If I fall and break my leg, and I have myself so medicated that I can't feel anything, how am I going to know when it's safe to put weight back on there, right? You know, all of a sudden, you know, I'm trying to not take my medication. I have maybe switched to the over-the-counter medications, and I put a little pressure in there, and I know, hey, you know, this still hurts. I have to, you know, still really do some things. I have to get back to therapy or whatever, but sometimes it's okay to feel a little bit of pain. I don't know if there's anyone in this room that can say every single day they are 100% pain-free, right? It's just a part of being a human. So nothing that we're going to give you or any other modality that we use is going to take 100% of the pain away. So these are the things that we have available in our community. First one, different sort of injections that you could come in. I know people don't really like the idea of shots, but they really are helping people for a relatively long time. It's used to reduce joint pain and inflammation. So hips, knees, elbows, shoulders done right here at the clinic. And people are getting pain relief from these for a good couple of months sometimes. So if there's something that you could come in, yeah, it's maybe miserable for a couple of minutes, but if it can give you a couple of months pain-free, you know, I think it's worth it. There are also injections that they can do for back pain. However, we do refer those out. the creams and patches. We've switched to a lot of these now. People get, especially for back pain, they'll get the patches over in the pharmacy. And this basically works as topical. You know, the medication is absorbed through the skin, and these do work significantly well in a large percent of our patients. Physical therapy. Physical therapy is something, most of these things are different sort of interventions that can be done safely on everybody, you know, baby through adult. Right now at the clinic, we have 2 licensed physical therapists and 1 physical therapist assistant. We have physical therapy services available 5 days a week, every day at the clinic. You simply need a referral from your primary provider, and we will get you an appointment to see one of the physical therapists. It's a branch of medicine that uses exercises and a lot of hands-on. We have a very nice fitness center in the clinic. Oftentimes we will see the physical therapist up in the fitness center with the patients, you know, helping them a little bit, you know, different weights and biking and things. Yes, this is slower, but this is long-term results, right? I can keep throwing pain pills at you for the next 5 years, but if I've done nothing, you know, to help get to the bottom of what's causing that pain, what have we accomplished, right? So when we're talking about something like physical therapy, we can actually help what is causing that pain, and we can eliminate the need for these pain medications. So these are all sorts of different reasons that people are using physical therapy in different conditions that can be helped by physical therapy. We have chiropractics. We have a chiropractor at the clinic 2 days a week, Dr. Brian Greaves. This again, very appropriate, child through adult. You'll get a referral again from your provider. Contract Health will help pay for at least 5 sessions. If those sessions, if they feel that there is improvement, if you are making, you know, some gains, you're going to be approved for more. So, you know, this used to be all done by referral, but now he is actually at our facility 2 days a week. And these are different conditions that we do refer to our chiropractor. So again, back pain, probably #1 thing that we see. And, you know, you're going to see every single slide from now on that's going to say, will help with back pain. Massage. You know, this is something that is very comfortable to do. Our massage therapist is available 5 days a week. Again, all ages. This is safe. Requires, again, a referral from your provider. They'll just give you a little card. You go up to the appointment desk. You make an appointment to get a massage. You know, it is very, very calming in there. I love walking by his rooms. There's usually very soothing music playing, really good smelling oil coming from his room. So I don't know why anyone would turn this down. You know, if you were able to get massages paid for, you know, with your health insurance benefits. Massage can help to reduce that heart rate, which in turn will lower your blood pressure. It also relaxes the muscles. It improves our range of motion. It just really gets, you know, our lymph system going, our blood system going. And those are common reasons that folks are referred to go to massage therapy. Exercise, again, all ages, kids can exercise. We have a fitness instructor at our facility. In fact, we have 2 now, I believe, that are available every day too. They will help you work, you know, different sorts. This can be, you know, rehabilitation from injuries and accidents. It can be for weight loss, you know, to do things like get your diabetes or blood pressure under control a little better, but it is also really good for pain as well. So, conditions improved with exercise. And finally, acupuncture. Acupuncture is available at the clinic 1 day a week. It is actually Dr. Gunther's wife, Dr. Fang, who does our acupuncture. And it's just basically Inserting those very fine needles is not a painful procedure. Acupuncture has the least amount of cancellations and no-shows in the entire building. This is a very, very popular service. People feel very good when they have it done. They are getting very, very positive results from this. So although it seems kind of like it might not be the most pleasant thing, having those little pins, inserted there, very, very thin, different sorts of points of entry all over our body that can help many different conditions. And these are some of the reasons that we use acupuncture. And lately we have been trying some of our groups that we are having at the clinic, our substance use disorder groups. Dr. Fang is there during the time that one of those groups meet. And she has been going and doing just some very, very slight, minor little acupuncture things on these patients. And they really have some great comments about this. They're really enjoying it. And finally, behavior health. And people oftentimes have a very hard time accepting that physical pain may be due to a behavior health type condition. And don't often see, that connection. Like, I'm having pain, why are you sending me to a counselor? But we know that oftentimes emotional pain has symptoms that are physical pain. Undiagnosed, untreated depression and anxiety are the biggest cause of physical pain. And that is statistically throughout our whole nation, not just here. So how can behavior health actually help when we're having chronic pain? So pain causes stress, stress causes pain. It's kind of that non-stopping cycle there. Sometimes just helping us, going back and visiting different things, changing those negative thoughts. There are some things that are just so painful that we just refuse to deal with them, right? And so we will start to medicate ourselves. And sometimes just going through, and as painful as it might be to talk about some of these things, learning how to process those memories in a whole different way, and bypassing that stress and anxiety and that pain, and improving our coping skills can oftentimes relieve our physical pain. Behavior health services at the Menominee Tribal Clinic, available every day. We have walk-in intake once a week on Thursday afternoons. We have 4 master's degree counselors, 1 psychologist, and we have 2 visiting psychiatrists and psychiatric nurse practitioner. We have counselors available in this facility. They're not all about AODA. We could come here for mental health, we could come here for grief counseling, all sorts of different things. The County Human Service, I see Drew here, our employee assistance program. So many, many different places in our community that you can go to if you think that, that there is still something in your past, something that's recently happening that may be bothering you. Go ahead and get a referral or just seek out the services of a behavior health. So we are here delivering the message. Please help. If you suspect that someone is abusing prescription drugs, please. Lately we have had a run of patients at the clinic coming in who are expecting babies, pregnant moms coming in asking for help. And that's a really hard thing to do, right? Because if we think that there's a stigma attached to drug abuse, add a pregnancy in there, and then we really got a stigma, right? So these women, it takes so much courage to come in and ask for help. We don't turn people in. You end up at the emergency room, they have no choice. We do have to make calls to human service and social service. You come to the clinic, you're honest with us, you ask for help, you let us help you, you follow through with your treatment recommendations. We are not calling, about you. You are doing everything you can. So what can you do? First of all, don't ever start this, right? Don't think it's okay to use these medications. If you suspect that someone is using, abusing, if you suspect someone is selling, please call the police right away. Please, let that be known. Don't let that go on in our community. And please encourage them to get help. Tell someone, cannot sleep off an overdose, is with a patient. We really do the whole team approach to our folks in medically assisted treatment. I see them at least weekly and talk to them. Sat with one not too long ago after that 20-some-year-old passed away in our community, and he said there were all sorts of people around him, but no one made that call. That could be me. Would someone call about me? So you know what? Yeah, there might be legal problems, right? If the police officers walk into a scene that someone's on the verge of death and there are drugs there, yes, there may be some legal consequences. But you may be saving somebody's life. So if you're scared, if you think that someone has had too many drugs, if you see it being sold in our community, please make that call. And always remember that you could be saving someone's life.
So first we're going to talk a little bit about our service. We're an advanced EMT service providing advanced life support, so we are not a basic service only to the Menominee County Reservation. Our first ambulance out the door has to have at least one advanced EMT providing ALS support. What reservation substance abuse studies are saying, this is reservations across the nation. Many of us already know this, that there is a higher substance abuse with Native Americans and other cultures. The rate is much higher on Native American youth, and a lot of that's been discussed already about the access to getting pills and access to getting drugs. And the reason behind all this is because of the high unemployment and poverty, creating easier for drug traffickers to exploit reservations. What is the one business we have on the reservation that has the most cameras, but it makes it very easy to do drugs? Anybody? Casino. We see it a lot. A lot. I think the sheriff can attest to that. So, we have a large list of drugs of abuse. We're going to talk about what we see in this community. We see alcohol, that's number one. That's always been the number one thing. I don't think it's going to go away. For the longest time we saw synthetic marijuana. It's still there, but it's not as bad. We're seeing more and more heroin. Cocaine's kind of leveling off right now. Meth is increasing, and prescription drug abuse is skyrocketing. And then there's a few others that aren't limited to this list that we'll talk about later. So we'll first talk about synthetic. When it was first introduced here, it became a major problem. It was from the children to the elderly. The youngest person I saw doing synthetic marijuana was 9 years old. I don't know why a 9-year-old this day and age would be trying to smoke something. The oldest that we've seen was age 74, and we've had several deaths, and it's been mainly in the older population from the synthetic. So when all the arrests were made from the dealers of the synthetic, we did see a significant decrease, but it is still very prevalent in the older ages, especially in the open. I still don't know the reason why it's in the open more than anywhere else on the reservation. Heroin is highly addictive, and our response to heroin overdoses has increased significantly. When somebody is on heroin, the major thing is the respiratory system is compromised. Fentanyl. As first responders, we have been taught to treat all drugs as if they contain fentanyl. The reason behind this is because fentanyl is so easy to get shipped over from overseas, but the fentanyl that's coming from overseas is comparable to elephant tranquilizers. So I'm sure everybody's heard news stories of these first responders or police officers that are coming in contact with this fentanyl, and they're dropping. I know it's happened in Milwaukee, Madison several times to police officers. The question is asked, well, what about the people transporting? How come it's not happening to them? Because they've already been exposed to it for so long, they've already been around it, they've already grown a tolerance against it, so it's not effective now. Cocaine is a stimulant drug. It is still popular today. We do have meth up here. Who remembers when it almost ruined Halloween? It changed a lot of the way we look at Halloween, and I think it's going to be continuing that we're still going to have the thing at the college because of that reason. All right, prescription drug abuse. It is one of our biggest EMS hurdles here. If it is a prescription drug, somebody will figure out how to abuse it. We see them snorting it, smoking it, trying to inject it. Doesn't usually work out. They manage to burn it down and inject it that way. I think anybody that knows me knows how against I am of gabapentin. That is our #1 abused drug on the reservation. In 2017, the tribal clinic gave out over 400,000 pills of gabapentin. That is enough for everybody that lives on this reservation for like a year's supply. So now it is first being questioned as to why are we giving out so much gabapentin. Don't get me wrong, it is a useful drug for people that need it and use it correctly, but we are seeing more and more people that are abusing it or stealing it, especially from the elderly, and abusing it, selling it. If you hear the word Johnny's, that's gabapentin. Over the counter, Imodium. People have learned how to abuse Imodium. I challenge everybody to go to Shadow Walmart, even though I don't even like going there, but look at how much Imodium they don't have on the shelf. I know people that work at Walmart, they tell me they get a shipment of Walmart of 7 cases. So we're not talking like little things, but we're talking to actual cases. They'll get it on a Wednesday, it will be gone by Sunday. People have figured out that if you take 20 to 30 Imodium, you can get high from that. I don't think you'll ever poop again, but apparently you can get high from it. Bath salts are still out there. We don't see a lot of it on the reservation, but we have had a few calls. Those people are the ones that mainly think things are crawling out of their body. They are very violent. They get violent with us. I think part of the reason we still see a few of the bath salts is because it's still a big thing in Western Channel County, which is like your Mattoon, Burnhamwood, and then Eastern Marathon County area. Apparently they haven't gotten out of the realm of the new drugs, so they're still having a lot of issues with their bath salts. Every county seems to have their drug of issue as the years go by. Waupaca County is still heroin. Shadow County is meth and heroin. Western Shadow County is bath salts. Lincoln County. Okay, so if you look at Lincoln County, it is filled with nothing but hunting land. So it is the perfect place to make meth. These guys go into break into hunting cabins, make their meth, leave, and then when the hunters actually come to their cabins, and then they're exposed to it when they walk into their cabins. So yes, we can go on and on and on. Sudafed, we all know it's out there. The Imodium still blows my mind. If anybody can figure it out for me, please let me know. A little bit more about the prescription drug abuse. Painkiller overdoses in Wisconsin has increased 238% among ages 10 to 24. So we had a 90-year-old here on the reservation, but now we're talking about Wisconsin as a whole, and that's based on ages 10 to 24. We talked, Myrna brought up about seniors. Last year in Wisconsin, EMS programs transported nearly 1,000 seniors with an unintentional opiate overdose. So how can that happen to our seniors? Any ideas?
Forget when they took their pills.
Exactly, that's exactly it. They forget when they take it. Oh, I didn't take it, so I'm going to take more. Luckily, we have community health that is very vigilant in making sure that that doesn't happen, where they come in and they do the week supply and that's all they get. They don't get anything else, they don't get anything more. So that's where all our programs within the clinic come to help. I'll talk about them a little bit more in a minute. So now we're going to talk about Narcan. Narcan counteracts opiate overdose. Our ambulance service has been giving more and more Narcan as the years go on. With that, we're learning we're having to give more doses of Narcan to patients because the drugs are getting stronger. containing more fentanyl, containing other things. The most Narcan I had to give to a patient was 8 milligrams of Narcan. So that's 4 doses of Narcan. Before he woke up, and when we said, you're the luckiest person alive on the reservation right now because you're still alive. Because his friends, when he overdosed, threw him in a shower and just turned the shower on and left. Then somebody else came and found him. With getting that much Narcan, he would have died if nobody else came in and found him. Is he still using? I don't know, we haven't had him since. Maybe I scared him, I don't know. We carry more Narcan on the ambulance now than when we first started carrying it, not only to protect ourselves, but police officers and other people that might come into contact with these drugs. It is unfortunate because I just read an article that now they're talking about putting Narcan in homes, which we've known people have been able to get Narcan, but yet we can't get epi or insulin because it costs too much. It doesn't make any sense. In the state of Wisconsin, every ambulance service has to do the reports based on the state system. And then all that data is collected and pulled. Well, we already know the reservation. We have the sickest people per capita and the highest trauma per capita. Last year we gave 30 patients Narcan, so that's at 1.3% of our runs. So we have a population of over 5,000 people. That rate of giving Narcan is higher than the state average of 1.1%. We have also given more Narcan than Milwaukee, which has a base population of 1 million people. So we do have a problem. Brown County was 1.1% and Milwaukee was 1.2%. Yes, they gave out more Narcan based on their population. So if you look at our population, we gave 30 out of our 1,000 calls. We have a problem.
Let me pull them out. Get them on the ground. Get them on the ground. Sir. Pulse.
What's his medical history?
I don't know. They just picked him up 10 minutes ago.
You just picked him up?
Yeah, he's like, I need some money. Can you put me to work? And I said, yeah.
He's got a pulse. He's breathing, so.
Can you grab gloves?
He's not breathing. I don't know if drug related. Give me a flashlight. I can't see his eyes. Yeah, they're pinpoint. Go left nostril. I-6 Narcan deployed in the left nostril.
Use mine?
Excuse me?
Use mine?
No, it's just the one.
This one?
14, 15. Rescue, they might get here before
No,
you.
it doesn't go there. It's right there.
Go ahead, put it on them. There you go. There we go, hold on. All right, take it off. Got a pulse, barely breathing. You just try to take a breath. His eyes are in There he is, 3 minutes.
So that guy was pretty calm when they finally woke him up. We usually have people that aren't so happy that we woke them up because we're taking them out of their high and they're very violent. We have done training with Travel Police, Sheriff's Department, and Conservation. I still can't answer who's out carrying Narcan though. I know some of them are. I know the Naji drug guys are carrying Narcan on them. So again, with the police carrying Narcan, it's not only to be out there on the street just giving it to people, it's for their own protection as well if they come into contact with stuff, because they can hopefully recognize that they've come into contact with stuff and can give to themselves. I can guarantee you we have come into contact with stuff on EMS calls. And it's not trying to be funny, but it's just like, I guess it's a bad EMS humor. But we're in these houses with these people, and we get back out and we're like, hey, I'm feeling pretty good right now. And, you know, it's not right, but at the same time, it's just like, holy cow, you don't think of it, but man, maybe we should have got tested to see what it actually came into contact with, and we never did. So it's unfortunate that it has come to that even we have to be scared and protect ourselves, but I think that's the norm everywhere now, unfortunately. The family helps stop the cycle. So we all know about historical trauma. Those that have not done the Trauma-Informed Care series, I definitely encourage you to do it. I encourage all our EMS staff to do it when we first hire them, because we do hire people from outside that don't know what the history is. It is very hard to walk into a house repeatedly and to wake somebody up from an overdose while their kids are right there, their babies that are still in diapers walking around. Is dad gonna be okay? Or wake up now, dad, because they've seen it before. That's how we're not stopping the cycle. And I think Dr. Gunther had brought it up about the kids seeing it. To them, that's normal. That's their everyday life. We have a lot of programs available in the community. And I know in EMS, we only spend 15 to 30 minutes with a patient, but those 15 to 30 minutes can totally impact somebody's life. We had a girl that was repeatedly overdosing. And because I am part of the administration team at EMS, I get to see all of her reports, so I get to see the repeat patients. So the first time that I had her was my chance to reach out to her to say, hey, what is going on? Why do you keep overdosing? Why do you keep doing this? We have programs in the community. You can go to Manaseke, you can go to the clinic. Well, here to come find out, she was going to the clinic, but she wasn't happy with her counselor. And being 16, she didn't know she had the option to say, I want to talk to somebody else. So I told her, you can talk to somebody else. If you're okay with it tomorrow, I'll go to behavioral health and talk to them. That is the biggest advantage that we have in EMS, by having EMS at the clinic, is that we can do that continuation of care without it being a HIPAA violation. I think everybody knows about HIPAA, it's the confidentiality stuff, that I can go to Diane, and I have gone to Diane to say, hey, we had this patient. It was totally not related to her drug abuse. She has a medical condition, but we think she's abusing. Can you reach out to her? We got her to come into the clinic today. And that's the best part of having EMS at the clinic, is that I can walk into the clinic the next morning and be like, hey, that patient is sitting there. They say, thanks for getting me, into the system. That girl, she did end up finding a different counselor that she was able to connect with, and we haven't seen her since. So that's something that's, I guess, positive. Felt good for me on a positive end, is that, we're not having to see her anymore. We haven't seen her for months, so. Anybody have any questions?
Are they mixing cocaine with fentanyl?
Yes, everything. We have had a few even people with synthetic that were known synthetic. Paraphernalia was there, everything showed synthetic, and we gave the Narcan and they woke up. So we know they're mixing it with everything. And like I said, the whole synthetic thing is still there. It's not as bad, but we know it's still there. We know they're finding anything they can to mix. They take household chemicals now. So if you know of anybody that is still using the synthetic in the community, just encourage them as best as you can to get help. I mean, we all know it's hard. Addiction is hard. We're all addicted to something. I smoke. I'll be the first to admit it. But if we can get people that just one person to get them away from it's the best thing we can do. I know there's a lot of jail people here, so I'm gonna pick on you. Oh, he knows. I'm not talking to you about this too. Putting people in jail because they have an addiction problem is not the answer. Our jail does not have staff to babysit these people, to watch them, to go through the withdrawals, to get them the help that they need. We know the pregnant moms is a big problem, and we see it in EMS. The idea is, well, let's just put them in jail. That's going to get them off the drugs. That doesn't work. That doesn't work, turning somebody in like that, because you know what? Then that baby's going through withdrawals too. So then you have two people going through withdrawals, and they're still not getting the help. So jail is not always the alternative. So if you have somebody like, oh, they got a warrant, they're on drugs, I'm going to put them in jail. It's not always the best case because they're not getting the help. Can you, and maybe instead say, hey, let's get you down to the clinic. Let's get you in to see the doctor. Then they can meet with Diane and get them into the system that way instead of just throwing them in jail. Let's worry about the warrant after they're off the drugs.